angiography in posterior and panuveitis cases. We had no financial disclosures. The aim of our study was to establish the importance of ICTA in analyzing the choroidal inflammatory lesions which involve the choriocapillaries and the choroidal stroma. The maximum ICT spectrum, where the maximum light absorption is at 800 nanometers, and it in turn emits the fluorescing light at approximately 830 nanometers in the infrared spectrum of light. And at these wavelengths, it gives an access to the choroidal vascular structures to be seen through the retinal pigment epithelium. In choroidal inflammatory lesions involving the choroid, the areas of decreased fluorescence after injecting ICT, the areas of decreased fluorescence were seen surrounded by areas of increased fluorescence due to leakage from the large choroidal vessels. And this alteration of the slow choroidal inflammation process in choroidal granulomas was the main parameter used in ICT angiography. So there were two types which for clinical interpretation, ICT hypofluorescence and ICT hyperfluorescence. In ICT hypofluorescence, we could see in the space-occupying lesions of the choroid, we could see decrease or absence of physiological extrusion of the ICT macromolecular complex from the choriocapillaries, and all the choroidal granulomas presented with hypofluorescent dark dots in the intermediate phase of angiography. And if this hypofluorescence remained hypofluorescent in the late phase, it signified that the inflammatory lesion occupied the whole thickness of the choroid. And when the lesions became isofluorescent in the late angiographic phase, the inflammation caused only partial thickness infiltrates, which delayed the fluorescence in the late phases. And the other type for interpretation was ICT hyperfluorescence. In case of presence of inflammatory foci in the choroidal stroma, there was diffuse hypofluorescence seen associated with hypofluorescent dark dots around the inflammatory infiltrates in the choroid. The adverse reactions seen with ICT were graded into mild, moderate, and severe. We did the study from 2010 May to 2011 June, which included 50 eyes of 27 patients. The inclusion criteria being posterior uveitis and panuveitis cases based on the clinical examination. The exclusion criteria were patients with history of allergy to iodine, patients with chronic renal failure or liver disease or pregnancy. After injecting 5 ml of indocyanine green angiography, photographs were taken at different phases of ICTA. Pre-injection monochromatic images were taken at early phase, which ranged a bit less than 5 minutes, at intermediate phase from 7 to 15 minutes, and at late phase from 20 to 30 minutes. We had 50 eyes of 27 patients, and the age distribution ranged from 9 to 27 years. We had around 13 males and 14 females in our study, and we had 23 cases with bilateral disease and 4 cases with unilateral disease. We had 11 cases of posterior uveitis and 16 cases of panuveitis cases. Out of 27 patients, we had around 19 patients of Vogt-Koyanagi-Haradas disease, 2 cases of sympathetic ophthalmitis, 1 case of tubercular choroiditis, 1 of toxoplasmosis, 1 of serpiginous choroiditis, 1 multifocal choroiditis, 1 MEWDS, and 1 chorioretinitis. Out of these 19 cases of VKH, we had 15 cases who presented with acute presentation, 3 cases of chronic presentation, and 1 had a recurrent case. Now coming to ICT interpretation, in the early phases, when compared to FFA, ICT showed multiple hypofluorescent dots and staining and leakage from the choroidal vessels. In the intermediate phase, ICT showed hypofluorescent dark dots with staining and leakage of the choroidal vessels, whereas FFA showed more number of hyperfluorescent dots with choroidal folds. And in the late phase, FFA showed a disc leak, increase in the size and the number of hyperfluorescent dots, whereas ICTA showed loss of normal pattern of choroidal vessels with hypofluorescent dots in the posterior pole. A case scenario, a 15-year-old boy presented with the history of penetrating injury in the right eye, and primary globe repair was done for that eye. 2 weeks later, he presented with diminution of vision in the left eye, and his vision was perception of light. The anterior segment of the showed changes of granulomatous uveitis, and the fundus picture showed vitreous haze with disc edema with exudative retinal detachment. FFA and ICTA pictures of early phase FFA showed disc leak, multiple point hyperfluorescence, and choroidal folds with inferior block fluorescence corresponding to the inferior retinal detachment. And ICTA showed multiple hypofluorescent dots in the posterior pole. The late phase in FFA there was a disc leak. In ICT there was multiple hypofluorescent dots with choroidal folds leaking choroidal vessels. And the same patient at 6 weeks follow-up, his vision was 6/12 with residual subfoveal retinal detachment and some pigmentary changes in the retina. The conclusion of our study was ICTA helped us to study the extent of choroidal involvement, which was not demonstrable by FFA, and it was helpful in diagnosing the subclinical granulomas in apparently normalized on clinical or FFA examination, and it also can be used as an ancillary investigation in addition to FFA and OCT to diagnose posterior or panuveitis cases.